Associate Professor Geoffrey Lam, he graduated from UWA in '83. He completed his specialist training in ophthalmology, and he's admitted to the Royal College that same year. He completed 2 fellowships in the USA in Paediatric Ophthalmology and Strabismus, the first of which was at UCLA, and the second was at Johns Hopkins in Maryland. Currently, he's the UWA Clinical Associate Professor in Ophthalmology. He's involved in the teaching of medical students as well as training ophthalmology residents, registrars and fellows. In 2007, he was recognised by the Royal Australian and New Zealand College of Ophthalmologists as one of the best ophthalmology teachers in Australia, with the Trainee of Excellence Award. So we're very lucky to have him with us today. He's currently a member of the RANZCO Paediatric Ophthalmology Special Interest Group and the Strabismus Society. He holds memberships in the American Association of Paediatric Ophthalmology and Strabismus and the AMA. In addition to his public hospital appointments at PCH, he also runs a private practice in Subiaco. So yeah, please help me in welcoming Dr. Geoffrey Lam.
Thank you. Good morning, everyone. I'll just bring my slide up. Good. All right. Right, so we are here. So today we're talking about the eye signs of Noonan's, as well as how we manage some of them. So let's get going first. Okay, so externally, the most common problem or sign that we can see is what we call hypertelorism. That means that the eyes are separated fairly wide apart. Up to 90% of the Noonan's have this. And downward slanting eyes, okay, that's about a third of them. And epicantic folds, as you can see here, the inside corner of the eyelid, or you can say the outside corner of the nose, there's this skin fold here. So that's called epicantic fold. It's very commonly seen in Noonan's, but do be reminded that we see that also in Asians as well, so I've got it. Okay, so it's not a pathology. And in fact, the first 3 so-called external eye signs, they don't usually affect eyes sight-wise. Okay, so we don't need to do anything other than for cosmetic reasons. They can be improved to a point if you want to. And okay, ptosis or droopy eyelid is also affecting about half of the kids with Noonan's. Okay. And a lot of people have problems pronouncing the word ptosis. Just remember the P is silent. If you can't remember how to pronounce it, just remember a few pieces of toast. Okay, so do we need to do anything about ptosis? The short answer is that unless it is affecting vision or threatening vision, we don't have to do anything. So sometimes when the eyelid is too low, it covers part of the pupil, it might block the vision, so that obviously needs to be fixed up. Or if the eyelid is very low, it compresses the cornea, the surface of the eye, and deforms the cornea, and that creates a certain amount of distortion. So that might need to be taken care of as well. And obviously cosmetic reasons, if you want to have something done about it, that can be discussed as well. More than half of the kids with Noonan's, they need glasses. Okay, they can be short-sighted, long-sighted, and the difficult thing is trying to keep the glasses on them rather than finding out the diagnosis. And lazy eye, okay, a third of them have lazy eye. Now, a lot of you mistake what a lazy eye, okay, is. So we just go through lazy eye in a medical perspective and talk about what you see on the screen. A lot of people refer a squint or strabismus or cross-eye as to a lazy eye, or some of them say that if the eyeball is not moving perfectly symmetrical, the 2 eyes are not moving symmetrically nicely, that's a lazy eye. Or somebody even called a ptosis, so the droopy eyelid as lazy eye, because the eye looks sleepy, so they say, okay, the eye is lazy. But in fact, medically, this is not what is a lazy eye. So what is a lazy eye in the medical terms? Okay, amblyopia is lazy eye. So, okay, eyesight develops in the first 8 years of life. So what happens is that the eyes see the signals, they send the signals to the brain, and the brain will try its best to develop its capability depending on how much vision there is coming into the brain and what quality the images are. For instance, if you send perfect vision to the brain will try and develop its capability to its full capacity. But if you only send crappy image to the brain because of something wrong with the eye, then the image perceived by the brain is terrible, and the brain can only match its quality development with what it perceives. So that's lazy eye. In the first 8 years, we've got this period of so-called elasticity or plasticity, so the brain can cope with it and try to improve. But after 8 years old, if you have not completed the improvement in the visual quality, whatever happens at 8 years old, sight-wise, will stay on forever, as you can see there. Okay, so as I said, vision develops in the first 8 years or so of life. Let's assume that this photograph you see is what we see as a grown-up. Okay, at birth, this is what a baby approximately sees. It sees less than 10%, so in terms of legally, that's called legal blindness. And by a month old, it's a tiny touch better, but still not a lot better. 2 months old, not much better, but still seeing silhouettes maybe. 3 months old, they start to see a bit better. And by 6 months old, a lot of them can track things, fix and follow things. And it's not until 3 years to 6 years or even later before the eyesight attains adult visual capacity. So it takes time for the vision to develop. So if something happens to one of the eyes and the brain is not seeing the good quality images in this first eight years or so of life, what they see is this for the rest of their life. In 1981, Dr. Hubel and Dr. Wiesel won the Nobel Prize on their investigations on amblyopia, or lazy eye. So what they did was they stitched up the eyelids of one of the eyes of young kittens. And after a few months of doing so, they sacrificed the kittens, and they cut the brain up and stained the visual center in the brain. And in the normal uncovered eyes of the kittens, the brain part serving vision for that particular eye, you can see these are the brain cells serving visions. They stained up. But in the stitched up eyelids kittens, you can see that there are a lot less visual cells there. So a lazy eye, in fact, is a pathology of the brain. So we should call it a lazy brain rather than a lazy eye. So the short answer is that we need to fix up any potential causes causing lazy eyes before the kids get to 8 years old. So what are the causes of amblyopia? Okay, poor focusing. For instance, if one eye is very long-sighted, one eye is normal-sighted, then the brain will decide to use the good eye and forget about the other eye. So the poorly focused eye, it will become amblyopic. Or if the child has a squint, a cross eye, a turned eye, okay, the brain is getting confused because the two eyes are not seeing the same thing. So the brain will say, okay, let's use the straight eye and let's forget about the turned eye. So the brain actually suppresses the image of the other eye. So artificially or physiologically, it creates a cover on the turned eye. So the child does not see double, but then the brain is not using the turned eye. Or poor clarity, for instance, if there's something blocking the vision of one of the eyes, so the brain cannot get signal from that eye, like a cataract, for instance, and so the brain will just use one eye, so the other eye becomes amblyopic. So this is a photograph of a cataract. You can see that this is the lens, but in the middle here, the whole, you can say there's an opacity that stops the proper images from getting inside into the eye and hence to the brain. So yet again, as I said, okay, these photos you see here, that's not what we call medically a lazy eye, but they are causes of lazy eye or amblyopia. So that's why a lot of people mistakenly call them lazy eye, because they see this, they don't see the lazy eye. Lazy eye is a condition that only after testing that you can tell that there is lazy eye, but just looking at it, you can't say that somebody's got a lazy eye. But if you see any of those conditions, they need to be assessed for lazy eye. So how do we treat lazy eye and amblyopia? We treat the cause, okay? Whatever cause is causing that, we should treat that and patch the better eye to get the child to learn to use the other eye that he has not learned to use. Squint, strabismus, cross-eye, turn eyes, okay, that accounts for half of the Noonan's visual problems as well. Okay, so the eyes can be turning in, we call it esotropia, turning out, turning up, turning down. As long as the eyes are not straight, that's called a squint. In the British Commonwealth, we call it squint. Americans and Europeans call it strabismus, and whatever we call it, the eyes are not straight. Okay, so how do we correct that? Okay, how do we treat it? Glasses, okay, a lot of the kids with long-sightedness, they may also have a bit of a squint, and you just have to correct them with glasses and the eyes will come straight, as you can see here. So correct the so-called refractive error, and quite a lot of kids, that's all one needs to do. And we patch them too. Some of them have lazy eye and amblyopia, so we patch them, get the sight better. As the sight improves, the lazy eye can disappear as well. But patching itself is not necessarily a treatment or a cure of cross eye. Surgery, okay, if nothing works, if we fixed up the other bits and pieces, but the eye still turns, then we can do surgery. Okay, so each eye, we have 6 eye muscles turning the eyes in, out, up, down, as well as rotating them around the axis. So to correct a turn, a squint, cross-eye, what we need to do is either to strengthen one muscle or weaken one of the muscles. For instance, okay, if the eye is turning inwards, okay, with the 2 muscles, the inputting muscle as well as the outputting muscles, they are not balanced up. So we want to weaken the inputting muscle by relaxing it, like just now, like that photograph we got. Or we can strengthen it by shortening the muscle, like so. Okay, so we pull the muscle, shorten muscle closer, so it's tighter, so it works harder, it works faster, it works stronger. So in that sense, we can correct a turn in the eye by operating on a couple of the muscles to balance up the turn. All right, now there are no children here. Okay, good. Okay, now the next slide is a bit bloody, so anybody under 18 must shut your eyes because it's R-rated. Nobody under 18 here? Okay, all right. So a lot of people ask me, when we correct it, do we take the eye out? No, the answer is that no, we don't have to take the eye out to correct a squint. Okay, so I'll show you some photos how we do it. Okay, so first of all, we get hold of the eye, and then we make an incision in the conjunctiva. So we have a little opening in the conjunctiva, and then with a special muscle hook, we hook up the muscle that we want to operate on, and expose the muscle, and put in stitches, or do whatever you want to the muscle, and cut the muscle off, and in this case, we suspend the muscle further back. So this is a weakening procedure. We relax the muscle, okay, and then we close up. Okay, so everything's done on the eye surface. There's no cut on the skin, and after surgery, other than some minor pain, the child is allowed to go home the same day. So it's not like having to take the eye out. Okay. Some of the other eye problems that we just briefly talk about. Optic nerve hypoplasia is another thing that we see, not very common, about 10% of them, but optic nerve hypoplasia means that the eye nerve, the cable connecting the the eyeball to the brain, the electric cable is hypoplasia, smaller. Normally in the optic nerve we have about 1.4 to 1.6 million nerve fibers. So imagining you've got electric cable with 1 certain million electric wires inside. When it's smaller, hypoplasia means that it's smaller. Let's say you've only got, let's say, 5,000 wires left. So most of the signals cannot be transmitted into the brain for the vision part of the brain. So, so eyesight is obviously affected by optic nerve hypoplasia. So as you can see here, this is the inside of the eye as we look from the front. This is the optic nerve here in the normal one, but in the hypoplastic, smaller eye nerve, you can see it's a lot smaller. So a lot less signals are transmitted to the brain, so we have a sight problem because of the physical poor development of the optic nerve. Nystagmus, okay, you can see wobbly eyes, okay, 9–10% of the children with that, with Noonan's got nystagmus. You can see the eyes jittering. Sometimes can go up and down, but most of them are sideways jittering. And usually that's a sign that there is some sight problems. I always explain to the parents, okay, the reason why there's jittering is that the brain wants to see better, so it instructs the eye to look at something good so the brain can see that something. But because the sight is not good, the eyes are moving around to try and locate that something to satisfy the brain. So that's a simple way of explaining why the eyes are jittering. Okay, but in most of the cases, we don't need to do anything about it. Just treat the cause. Cataracts, okay, up to 10% of the Noonan's kids have cataracts. Now, cataracts by definition means that the lens is not clear. As you know, the lens is the focusing part of the eye, just like a camera lens, okay? If the lens is not clear, then that will affect the vision. So many different types of cataracts, okay, like this one, we call this a nucleus cataract here, is in the middle, and this one is like a little comet shape that's on the surface of the lens, and that usually does not affect the eyesight. And this child has cataracts in both eyes. You can see that the pupils are grayish looking, and this one here is in the back surface of the lens itself, but it occupies the central part of the lens, so that will affect vision as well. So not all the cataracts cases will need surgery. We do the surgery only when there is a sight reason, as in the sight is affected. Okay, so another warning, okay, I'm just going to show you a brief video of how we do a cataract surgery. So we make a very small incision, as shown there. There's a 3.5 millimeter incision, and through that incision, we put a special gadget in the eye and suck out the cataract, as you can see. This is obviously fairly much abbreviated, so it takes a bit longer than that to do it. Okay, and then we put an artificial lens inside. So the lens itself, the diameter of the focusing part of the lens is about 6.5 millimeters, but we fold it up in half in this case, and we can actually squeeze that through a 3.5 millimeter wound there. So that's a big lens going through a small hole, and then we release the clamp, which you will see shortly, and see the bouncing open of the intraocular lens. And then we just position the lens in the correct position, and then that's the procedure done. All right, good. Oh, okay, that's it. Okay, good. All right. Now, any questions?
Many.
Yes.
Many.
Good.
Just a bit of a trivial question. What is the cataract? Like you said, it's blurriness, but is it like fluid, or is it tissue that covers the lens?
Okay, good. Now, in a cataract in a child, the lens itself, now you have to, can you imagine the lens shaped like that? Round thing like a disc? Okay, now the lens, the anatomy of the lens is actually covered by an envelope, a capsule. So inside the envelope, the capsule, we've got lens fibers. They are transparent fibers. They are in a fairly well-organized matrix like that. Okay, so it's actually solid. Okay, so they are collagen fibers like, okay. And then for some reason, so the matrix normally is perfect in harmony, so light can travel, be focused and go through the lens. But somehow the matrix disturbed. Okay, let's say for instance, a diabetic who is not taking the insulin. Okay, so the blood sugar level stays at 20 odd for ages. Okay, the lens starts to absorb the sugar, and then it also absorbs the fluid, the water around it. So the lens becomes a lot fatter, and that disrupts the matrix. So normally a matrix like that, so now the matrix become like that. So it's no longer in perfect harmony. So once the matrix is disturbed, the clarity of the lens is gone, and then we get a cataract. So it's still solid fibers, but the matrix is disturbed, and so we've got opacity of the lens.
Which is like collagen.
Yeah.
You're saying pretty much, okay. The other question that I had, it's come to mind, is you're saying a lot of the causes there that cause lazy eye. What are some of the causes of those causes? Are they just genetic abnormalities?
Good question. Most of the, say, strabismus, cross eyes, most of them are born with or genetically determined. Some of them are refractive, that means glasses problem. So that's the ones that we can correct with glasses. But a lot of them, you can say, if you ask a geneticist, they always say it's genetics, okay, something in the family, the genes. But yes, indeed, a lot of them do run in the family. Some of them can be secondary to something. For instance, if you've got a cataract, you don't use the eye is not recognized by the brain in that sense, so it decides to wander on its own. So it is a secondary cataract to disuse as well.
Okay. And with, I know when you said you had the cataract surgery, or not the cataract, the muscle, when you loosen the muscle, when you had that surgery, it's pretty much just in and out in a day. What about if you have to have the surgery to fix the ptosis?
The ptosis.
Yeah, yes. So is that day surgery as well?
Different surgeons have different preference. In this hospital, our eyelid surgeon usually discharges the same day. But in some cases, when both eyes need to be done, you put patches over, then it's better to keep the child in hospital, at least until you remove the eye patch.
Yeah.
Is there any long-term consequences for the squint operation that you've described? Like in later life, if you've had it as a child, will there be any consequences for the operation of, the way the eye works later on in later life?
Okay, so we have to answer that question a few different ways. Okay, in terms of doing the surgery itself for a child, the aim is to align the eyes so the child can use the eye or eyes in sync, so that they have a pair of eyes to be used. The consequence, we say, of not getting the eye straightened up is that one of the eye will become lazy, so the sight will be affected. So we can say the consequence of doing it as a child is to make sure that we can have a chance for the child to use the eye, so that helps to improve or maintain the eyesight. Now, having done the surgery as a child, okay, if your question is, okay, does it last forever? I presume that may be one of the reasons you asked, okay? Now, not always, okay? We know, for instance, okay, there was this ophthalmologist in Italy. He's one of the gurus of strabismus, cross-eye surgery. So when he retired, he looked back at his 50 years of strabismus surgery. And being a guru, in the first 10 years or so, he looked at the numbers of the patients. 80–90% of them were perfectly straight or doing very well. But then if you look further back down the track and say 50 years later, how many of his patients were still holding the eye straight? And he found that only about 50% of them were still straight. Okay, now, not straight doesn't mean that they need a second operation, just that by measurements, okay, we've got so-called fixed definite guidelines, measurement guidelines as to what we constitute as straight, what is not straight. Okay, so within 5 degrees of being perfectly straight is considered a successful surgery. So 50 years later, he found that, okay, not all of them were within the 5 degrees of straightness, but they could still be doing all right, as in looking cosmetically fine. So it's not that every 50% of them will need further surgery. So that's his statistics anyway. So the short answer to your question is that not all of them will stay straight in time, but by and large, in terms of complications, consequence, okay, they don't necessarily stay straight, but a lot of them will stay straight, okay? And you can say 50 years of being teased by other people, calling them crooked eyes or whatever, it's definitely worth having the surgery straighten up the eyes to eliminate that name-calling thing, as well as giving them much better chance of using the eye, having better eyesight, eliminating amblyopia. But obviously, okay, there are other issues potentially, but not in the long term. If we're getting a problem with squint surgery, we will see it in the near short term. We won't be seeing it in the long term downstream. Okay, if there's a long term downstream problem, it's usually not because of having the surgery, but other issues.
This is more a comment. I think the definition lazy eye is a bit of a misnomer. It seems to me to be more like lazy brain, because it seems to me that sometimes there's no functional issue with the eye itself, but the brain is the one that's actually not doing the work. Do you think that's a fair...
Yes, absolutely, I agree with you. As I said earlier, it should be called lazy brain, but we don't have such an ability. And by labeling it as a lazy brain, that means that we actually have to get neurosurgeons involved, okay, because they should be doing the work. We don't have that ability, nor that skill, nor that knowledge at the moment, but I would say beyond my lifetime, okay, within the next 100 years probably, okay, it will be a tablet. You take a tablet, you get the amblyopia or lazy eye fixed up, okay. We know the problem is not using the eye, and we know if we get the eye straightened, remove all the issues, in theory you should get it right, but still there's something not right. So we know there is a chemical imbalance in the brain. It's likely to be dopamine. So if you can actually put dopamine into the head, we will fix up a lot of the lazy eye problem. Just that we haven't got that dopamine. Okay, dopamine, as you know, in Parkinson's disease, okay, they use dopamine to treat. So we have actually done a little trial using dopamine. We found that the eyesight did improve, but it did not sustain. In other words, we stopped the trial, the patients regressed. Okay, so all we needed to find is to have a good means of putting the dopamine in the head and make sure that it stays there, then we'll fix it up. Okay, so that's one of the targets of some of the researchers in the world, is to find out what is this chemical that we can use. Yes.
Hi again. So when my daughter was born, they told her she was born with small irises in her eyes, and they sent her off for an MRI to check the optic nerve at the back. Came back, the optic nerve was fine, so there wasn't any issue, but they had to keep monitoring and measuring her irises. So what's that about? Like, how can having a small iris affect things?
Yes, so I would imagine what they meant, or what we meant, probably one of my colleagues, is that she has smaller eyes. Okay, so eyeballs are smaller, so you get smaller iris, smaller cornea, smaller everything. So that's what we call micro-ophthalmia. So smaller eyes or smaller this and that, okay, means that the focusing is not perfect. Okay, you might have a perfectly normal cable, the optic nerve, but the front end camera is not focusing well, because a normal eyeball length, should we say, in a grown-up is about 24.5 millimeters in length from the front to the back. At birth, a newborn baby is about 16.5.9 millimeters diameter. In the first year, the eyeball grows rapidly, grows up to about 20.5 millimeters. Second year, it grows to about 22. And then from 22 to 24 takes about 15 years. Okay, so when the eyeball is smaller, just imagine that, okay, you're trying to focus an image from the front to the back. So the image is normally focused, say for a grown-up here, but when your eyeball is too small, too short, your image is focused behind the focal plane, so the images are distorted, you can say. So they usually have a fair degree of long-sightedness because the eyeballs are smaller.
Right.
And so that means that, okay, besides the other things, okay, obviously if the eye is smaller, then your seeing apparatus, okay, like the retina, the lenses, they might not be perfect as well. So there are other consequences of having a smaller eyeball as well.
Okay, that's interesting.
Up the back.
Hello. So this isn't necessarily a question regarding vision.
Yes.
But my daughter has blue sclera.
Yes.
And I'm not sure whether that is anything that is seen in many people with Noonan's, or is it just something that has occurred within her development?
Yes. Well, how old is your daughter?
She's 8.5.
8.5.
Yeah.
Still blue.
Yes.
Okay.
It's
right.
not as blue as it was a few years ago,
Okay.
but it's still present.
Right. Okay. Now, blue sclera is, I don't think is necessarily a sign of Noonan's, but it's basically the white of our eyes look white normally, as you know. Okay, but the layer underneath, that's inside the sclera, that's the white part of the eye, is a pigment epithelium. Okay, it's dark brown in color. And then we've got the retina in front of that. Okay, so what happens in kids who have slightly thinner sclera, the white part of the eye, the blue or the brown shows through, and it looks like it's blue in color. So just like when you bruise yourself, okay, I mean, how come it's not red? Because the skin filters it and changes its color. So the blue sclera is a sign that, okay, you're seeing through the white part of the eye. Most common cause is normal. Okay, a lot of kids have a slightly thinner white of the eye, so we can see that. But there are other causes of blue sclera, usually a collagen type thing. It's not a sign of Noonan's, but
Yep.
I'm sure it can happen in Noonan's
So
as well.
could that in turn also be an effect, like with the collagen being weaker, would that be a reason why she has like the strabismus issues as well then? Like
No.
they're kind of correlated in a
No,
way?
the strabismus is not related to that. Okay.
Cool, thanks.
Okay. Wait.
Given the high prevalence of eye issues with Noonan syndrome children, is there a screening program within the ophthalmology department for children identified early with Noonan syndrome? Because I think our own experience, which is some years ago, was that we had to identify a vision problem for our child. He had congenital ptosis, which was quite obvious, but the development of his vision problems was something we noticed and that wasn't picked up through the paediatricians or anything else, and there was no routine screening, even, as I say, the high prevalence of vision issues. So are you able to address that or answer that?
Yeah, I think that should be addressed. And as Colin said, okay, there's a registrar coming up, and I think whoever goes in the registrar should have the eyes screened. There are lots of issues, political issues in particular. Currently, our eye department here, we've got more than 5,000 patients waiting for an appointment, so it is very hard to get patients in. So I agree with you absolutely that we should have the registry and then have the kids screened, no doubt about it. Okay, so for NF1, we screen most of the NF1s because I run a genetic eye clinic here with geneticists, so we see most of the NF cases in Perth. So we do screen them, but we'll talk, okay, and we'll set up something to try and fill in that little gap that I think should be filled in. Definitely, I agree with you.
Thanks so much for your time today, Dr. Lam.
Thank you. Oh, thank you very much. Thank you. I'll just leave this here.
Oh, yeah. Good.